Okay, perfect. So for all of you that have joined, thank you so much. Lots of familiar faces and some new ones. So this initiative is the Connecting California Fellow in Training lecture series, and we designed this lecture series in mind to invite speakers from institutions across California. And we want to highlight attendings out there who are practicing in unique niches of cardiology and might be practicing and seeing patients that we don't all necessarily see in our own fellowship training programs. So that's how our speaker list is generated. And I'm going to introduce myself. I'm Natalie Tapaskar. I'm a third-year cardiology fellow at Stanford, soon to be heart failure fellow, and I am the Northern California ACC FIT catalyst for this year. And I have a Southern counterpart who is an interventional fellow at Loma Linda named Nikhil. I think he's on call today, so I'm not sure he'll be able to join, but hopefully some of the Loma Linda colleagues can join. So I'm going to introduce our first speaker today. So we're so happy to have that our FIT committee member, Paul Morano, invited for us today, and we're really grateful to Paul for making the connection. So our first speaker tonight will be Dr. Siegel. He's a professor of medicine, and he works at Cedars-Sinai. He's the medical director of the Clinic for Hypertrophic Cardiomyopathy and Aortopathies, and the director of the Cardiac Non-Invasive Echo Lab. He's a leading expert in the field of cardiovascular ultrasound. He's involved in numerous clinical research projects and has been involved in clinical research involving the diagnosis and management of patients with Marfan syndrome and other aortopathies, as well as hypertrophic cardiomyopathy, pericardial, and valvular heart disease. Dr. Siegel has co-authored over 450 peer-reviewed scientific papers. He's contributed to more than 20 cardiovascular textbooks, and he previously served as the president of the California chapter of ACC and was the co-chair of the ACC 2014 annual meeting, as well as the co-chair of the National Marfan Foundation 2013 annual meeting. He's also a previous president of the Los Angeles Society of Echocardiography. We're super excited to have him today to join our California ACC FIT Connecting California lecture series and speak with us today about aortic diseases. Thank you so much, Dr. Siegel, for joining us.
Thank you very, very much for that very kind introduction. And now I'll get to the slides. If I can figure it out. There we go. So today, can you see the screen now? We're going to talk about aortic disorders, and I think it's a very interesting area. And this shows an aortic aneurysm. There's an aortic dissection in this plane. That's the plane. There we go. You can see the T and the MRI. But the thing about this is, just every day, this was in the news today, a Massachusetts hospital sit with a $29 million verdict after a patient died from an undiagnosed aneurysm. So you really have to have this on the back of your mind, because if it's not, it can be problematic. So I want to just give you that forewarning. The clinical presentations of thoracic aortic aneurysms, the scary thing about it is they're usually silent unless they dissect or rupture. And that results in about 25,000 deaths in the year, per year in the US. Risk factors are atherosclerosis, aneurysms at other sites, prior aortic dissection, if you have a unicuspid or bicuspid valve, if you have a family history of aortic dissection or thoracic aneurysm, if you have a cerebral aneurysm. High-risk patients are those with connective tissue disorders such as Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos, Turner's, and other connective tissue diseases. The mutations, if you're doing genetic analysis, are FBN1, TGF-beta receptor 1, TGF-beta receptor 2, and actually 3, 4, and 5, ACTA2, SMAD3, and MYH11 genes, all predisposed to thoracic aortic aneurysms. So when you see a patient and you're concerned about a genetic disorder, you need to screen for it. Usually we screen for about 33 genetic disorders. Now for aneurysms that are non-syndromic, but they're hereditary and no genetic cause, we've got an aortic team. You really need to have an experienced surgeon, and the threshold for surgery and for the root and the ascending aorta has been lowered from 5.5 to 5 centimeters in selected patients if you have an experienced team. In addition, if patients have a diameter that's greater than 4.5 centimeters, but they have high risk features such as a family history of aortic dissection at less than 5 centimeters, sudden death at age less than 50, or rapid aortic growth. These are patients you want to think about operating on earlier. Bicuspid aortic valve patients who'd like to keep an eye on, all first-degree relatives should be screened with an echo with bicuspid aortic valve because these people dilate their aortas. Surgery to replace the aortic root and ascending aorta is recommended when the diameter is over 5.5 centimeters. But surgical intervention is reasonable if the cross-sectional area of the aorta to height ratio is greater than 10 centimeters squared divided by meters, or if the aortic diameter is over 5 centimeters, but you have a risk factor for dissection, such as a family history, there's been rapid growth, you also have aortic coarctation. An aortic diameter of 4.5 centimeters at the time of surgery, if you're getting your aortic valve replaced, would be an indicator for surgery. Now, what about sporadic thoracic aortic aneurysms? In those patients, we treat them with antihypertensive medication. You really want the systolic pressure to be less than 180. We generally use beta blockers and angiotensin receptor blockers because in Marfan patients, these appear to be effective to reduce aortic dilation. In patients that have atherosclerosis, we use statin therapy and low-dose aspirin. And then again, keys to diagnosis, we usually start with a transthoracic echo, and we'll often supplement that with a CT and or MRI to assess aortic dimensions serially. These are patients that you are going to follow for a long time usually. Surveillance imaging then is done with TE, CT, and MRI, initially at 6 months, and then at 12 months, and then up to 24 months, and serially over time. Thoracic endovascular repair, TEVAR, is recommended over open surgery in patients who do not have Marfan syndrome, Loeys-Dietz, or vascular Ehlers-Danlos syndrome, and who have descending thoracic aorta that meets criteria that's suitable for intervention and suitable anatomy. I would say over time, we're seeing this area getting a little more muddied by TEVARs in patients that I've said shouldn't be done because they have other coexisting factors that make that more reasonable. Now, what's kind of cool to me about aortopathies is the plethora of physical findings that these patients usually have. And if you start with Marfan syndrome, hi, Paul.
I can proceed.
They tend to have tall stature, but not always, dislocated lenses, myopia, malar hyperplasia, high arch palates, retinopathia, pectus deformity. It can be, going in or out, scoliosis, aneurysms of the root or ascending aorta, prolapse of the mitral valve, dural ectasia, arachnodactyly. They also get inguinal and other hernias, and then get displacement of the femoral head of the pelvis, tend to have flat feet, and typically joint laxity. For the other aortic syndromes, they often have hypertelorism. Because of connective tissue issues, the sclera is blue. And sometimes that's the case even in Marfan syndrome. Malar hyperplasia, these all are really reflecting on the left what we see on the right, connective tissue disorder. Now, genetic mediated diseases can be described as syndromic or non-syndromic. And the syndromic conditions are Marfan, Loeys-Dietz, vascular Ehlers-Danlos, Schritzben-Goldberg, I can't pronounce that, SMAD3 disorder, which usually is aortic aneurysm often with osteoarthritis, cutis laxa with aneurysm, and Turner's syndrome. And these really deserve substantial observation and follow-up. Now, non-syndromic conditions can also be very problematic, and they usually have abnormalities limited to the cardiovascular system and it's often familial aortic aneurysm. They can with associate dissection, and bicuspid valves will have often can have an aneurysm, and up to 20% of thoracic aortic aneurysm patients have a first-degree relative with aortic valve disease. So what's kind of fun for me is you see a patient, you see that they have a plethora of abnormalities, and then you get to meet their family. And so it's a kind of a reinforcing event as a physician. Now here's an example of a Marfan patient, and he looks like it. He's tall, he's thin, you see he's got flat feet, the arms are long, the eyes are slanted down, he's got a pectus, he's got stria, and then in the slider you see a picture of a dislocated lens. To the right of that, you see somebody's back. People often will look for stretch marks in the abdomen, but the back is often the place where you may find them. And then chest mark, all abnormalities of any kind. And here the abdomen shows stria as well. And you look for flat feet. So when you see the Marfan patient, you're really examining them in a complete manner. Now here's a picture of Jacob Erdheim, who gave the diagnosis of cystic medial necrosis, which is the underlying pathology in Marfan syndrome, but it's not cystic and it's not necrotic. You have little pockets in the aortic wall shown in these blue little circles. And if you look at the normal aorta versus the Marfan aorta, you can see the elastin in the normal aorta is linear and contiguous, whereas in the Marfan syndrome, it's broken up and there's these little splashes. So that's sort of the pathology. We're making our diagnosis of Marfan syndrome. There are major and minor criteria. So family history is important. Doing the genetic testing is important, but you can be FBN1 negative in about 5% of patients. So it's not perfect. We expect to see aortic dilation, but it's not 100%. It's not uncommon to have this dislocated lens. And then there are multiple musculoskeletal findings that you can look at, but pectus is common, flat feet, positive wrist sign where you can put your fingers around your wrist, and a number of other musculoskeletal abnormalities, and also lumbosacral ectasia. Mitral prolapse can be seen. When you're seeing these people, you really have to look at the point here is the whole patient. That's what makes it really fun. And when we do all that, we then do genetic testing and see what we come up with. Now, let's go through some cases to make this a little more germane to real life. This is from a case from a 22-year-old man with Loeys-Dietz syndrome. He had intermittent chest pain for a week. So Loeys-Dietz, it's an aortic disorder that we worry about. And it was 3 out of 10 from peristernal to the back. Family history is father, a brother, and a cousin all had aortic dissection. So we're worried. This is an autosomal dominant syndrome, first described in 2006. It's got features that are similar to Marfan's, but the prognosis is much worse. And it's due to genes encoding transforming growth factor beta. And so TGF beta 1, 2, 3, 4, 5. And then in this picture here, you see on the ultrasound or the CT of the neck, the carotid arteries are aneurysmal and they're very looped. And in the picture of this patient, who's not the guy, she's got hypertelorism. You see the teeth. But what's classic here is the bifid uvula. If you see somebody with the bifid uvula, that's probably going to be Loeys-Dietz. You got to really worry about it. They also look for widely spaced eyes. They've got this hypertelorism, cleft palate and bifid uvula, and arterial and aortic aneurysms are really the worry. And again, what we saw on the CT is they tend to corkscrew. Now, these patients are at increased risk for aortic rupture and arterial dissection, and their life expectancy is only 37 years. So that's before they finish their cardiology fellowship in some cases. So, it's young. It's young, 32. So here's a 22-year-old guy. He's got Loeys-Dietz. He's had chest pain for a week. Shows up to the echo lab. And this suprasternal view shows kind of weird flow. We see the aortic arch, but you see red and blue flow there. And we pulse Doppler it, and it doesn't really tell us too much, but the pulse wave in the adjacent lumen is okay, and the arch it's okay. So what do we do next? Can one of you guys help me out? What we did is we did a saline contrast study into the left arm because it was unclear to me what this adjacent, where that flow was coming from. And when we do a contrast study in the left arm, we see that saline is going there into the left arm, and it's sort of, there's no dissection. This is the left brachiocephalic vein. So sometimes normal things can confuse you if you're not familiar with it, because normally we don't think about the left brachiocephalic vein. So Loeys-Dietz syndrome in terms of treatment is the ACC guideline. These patients have a high risk of death from aortic aneurysm and rupture. We monitor these people closely. We use angiotensin receptor blockers. Initially, we started with losartan, can really be any one of them, to decrease the TGF beta activity and hopefully slow formation of aneurysms and progression. And beta blockers similarly used to decrease heart rate, keep the blood pressure down, the distensibility of the aorta down, and decrease the left ventricular pressure generation to slow progression of aortic dilation. Prophylactic surgery is indicated in these patients much earlier than in other diseases. So if the ascending aorta is 42 millimeters by echo, that's an indicator. Or if you do a CT or MRI, it's 4.5 millimeters. So this is earlier surgery because these patients have a much worse outcome. Now here's a 43-year-old woman who is got Marfan syndrome. She's status post of Bentall, where they replaced her root and put a valve in. And she's got a biologic, or you can see her graft here, and she complains of sharp pain radiating to her back. She's had it for 2 weeks, and it was very severe the night prior to admission. Her pulse is 64, her blood pressure is 41. So we're very concerned about her. What would you do next? Well, the differential here includes artifact, a tear in the graft, or prolapsing dissection at or above the graft anastomosis. So which would you send the patient home to an MRI, a CT, or a TEE? Can I get a show of, just anybody say something? No one wants to say anything. Okay, well, don't talk.
I think
What?
I was going to say, I think I don't feel okay sending her home, and I think maybe a no radiation scan with an MR would be
Okay.
helpful.
Yeah, so I think MRI is good. Here we got the MRI on her. We went all the way. We got to see, we radiated her too. And which is, because this is a kind of little weird, she just got a kink in her aorta. And the kink results in the motion artifact that looks like a flap. But we were very worried about this young woman, chest pain and this thing flapping. So by 2 other imaging criteria, she didn't have anything, just a kinky aorta. And there's no reports that have been published on this, but echo reverberations can occur in a ptatic aorta, and they can be caused from linear artifacts that then suggest a flap or dissection. So to me, this I learned something. And the wall calcium causes a reverberation that can mimic a flap. And she had a lot of calcium. So kinks on CTA and MRI are a recognized finding in patients that have had surgery. MRI is better than CT through a lot of dissection in the setting of a kink. Okay, let's go to another patient. This is a 45-year-old guy, had been pretty healthy before, has syncope, chest pain, shows up in the ER. He was a construction worker, no other medical history other than untreated hypertension. He also had a family history that was positive for hypertension and coronary disease, negative for cardiomyopathy or genetic disorder. Goes to the ER here at Cedars, gets a stat echo to evaluate LV function and his LV and his hypotension. Troponin is mildly elevated, And his EKG shows, as usual, non-specific STT changes. We can't really understand those EKGs. Okay, does somebody want to comment about this echo? If you don't, I will. Okay, so it shows a significant pericardial effusion in the subcostal view, not that well seen in the peristernal view. It's got a 4-centimeter aorta. You see that the RV expansion is sort of struggling a little bit. And the patient's got hypotension, but minimal aortic dilation. The patient's not doing well, the blood pressure is low. Would you perform a pericardiocentesis in the ER, or would you perform additional imaging? If you do more imaging, raise one hand. If you'd perform a pericardiocentesis, raise 2 hands. If you'd send them home, raise 3 hands. I don't see any hands. Come on, I can see you. Natalie, you're not raising a hand. Oh, 1 hand. Okay. You'd what? You'd do a pericardiocentesis? Additional imaging. Additional imaging is what?
I think if the patient is clinically unstable, you would probably lean towards pericardiocentesis. But I think given the nature of this talk, I'd be worried also if there's a concern for aortic rupture and we're looking at a hemopericardium. So I think you might be leaning towards additional imaging. But if the patient's
You're
clinically
correct.
unstable.
No, but that's the point here. A 4-centimeter aorta is not normal. It's actually abnormal. And you've got this effusion and you don't have a cause. So I think you need additional imaging. And it's a good thing that you thought that, because type A dissections can occur in the absence of severe aortic dilation, even in a non-syndromic patient. So before the pericardiocentesis, we did a TEE in the ER to evaluate his root. And if I think what you can see here is it's a really ugly looking root. There's a clot in here, there's a section flap here, and the arch is a big dissection. So had we done a pericardiocentesis, as blood pressure gone up, this aorta could have ruptured. So you really don't want to get into that. So it's always better to get another set of images. Okay. So now let's digress back to aortic aneurysms. It's defined by when they have a dilation of an aortic segment more than 1.5 times the normal diameter. The aorta is big if it's more than 3.7 centimeters. They're nomograms for age and body surface area and a Z calculator. And when we measure the aorta, there are different methods of doing things, whether you measure it in systole or diastole, inner to inner edge, leading edge to leading edge, perpendicular to the aorta. You can do a Z calculator, but you just need to sort of figure out. Now here to the left is the way we're supposed to do adult measurements. That's in diastole. To the right is the way pediatricians are told to make their aortic measurements in systole. I think what matters most is how big is the aorta? I would get the biggest dimension because that's what ruptures. So that's what I worry about. And you want to measure the sinuses and look at diameters, widest diameter. You can use leading edge to leading edge. And whether it's systole, diastole, it's whatever's bigger. And here's some aortal linear measurements. If it's the sinus valsalva is more than 4 in men, 3.6 in women, et cetera, those are big. Now, in this slide, what this shows you is the probability of aortic dissection or rupture. And if you follow the diameters, when you get to 55 millimeters for the aorta, ascending or root, it's about a 3% risk of dissection. However, that curve is altered by the fact that a lot of these patients have surgery. And if you go by that, by the time you get to 50 millimeters diameter, more than 20% have had surgery, and that's appropriate. So it's very kind of a little bit confused what to do, but I think the idea is to operate before you get a problem. And this, to me, is a more scary slide, because this is a distribution of aortic size with type A dissections in non-Marfan patients with 3 cuspid valves. And look at this. 62% had a maximum aortic diameter of 5.5, less than 5.5 centimeters. 42% less than 5, and 20% had a diameter of less than 4.5. So that doesn't really fit in with our guidelines. And that's why Yogi Berra said, it's tough to make predictions, especially about the future. So we try to mitigate these things and look at the patient and sort of, you don't want unnecessary surgery. So but we've got some things. Now, this is the ESC and ACC recommendations, and pretty much the number to remember is 50 millimeters. If it's anything above 50, that's not good news. Now, patients should be considered with Marfan's if it's 45. With bicuspid valve, it used to be 50. Now the recommendation from ACC and AHA is 55. And if you have no elastopathy or vascular disease, it's more than 55. But this is a very controversial thing. And more, I'll show you. We'll get back to that in a second, are coming to a lower number. And so we would recommend elective replacement, but when we often look at the diameter as in relationship to height, and you can copy down this formula. I don't remember it. And if the ratio is greater than 10, surgical repair is reasonable. Now, here are some numbers. Ascending aorta is over 4. That's not benign. And even up to 4 or 5, it's not benign, it's highly abnormal. You really need to medically manage diameters of more than 4 centimeters. And I believe you should do this aggressively and pattern after treating patients with Marfan syndrome. And you really need to treat hypertension being critical. Pregnancy also increases patient risk. And so that's an additional worry these patients get into that. Ideally, the aortic area, diameters indexed to the height or body surface area and other risk factors. We look at family history, genetics, and hypertension, or if there's cocaine use. Probably in LA, we don't have cocaine use. That's probably more problem in the Northern California. Joking. Anyway, the other thing that you have to worry about is fluoroquinolone antibiotics, because those patients face a 2-fold increase in aortic dissection or rupture within 2 months of starting therapy. That's kind of shocking. Surgical aortic aneurysm. So with no additional risk factors, you pretty much go with a 5.5 centimeters. Bicuspid valve used to be 50. Now they're saying 5.5. That's sort of an argument in place. If we look at Marfan patients, Ehlers-Danlos-Turner syndrome, 50 millimeters, but some people would say 4.5 centimeters. If you're non-syndromic familial thoracic aortic aneurysm and dissection, again, 50, if there's a push to go to smaller. Loeys-Dietz, that's a much more problematic group. And so at 42, if the aorta is 42 millimeters on echo or 45 by CT or MRI, we recommend replacing the aortic root or ascending aorta. And if there's been an ascending aortic expansion in any of these groups of a 0.5 centimeter per year or 0.6 centimeters in 2 years, we consider surgery. And you have to think about risk factors like family history, aortic regurgitation, and height. All of those should be factored in. Now, how are we doing on time?
We could probably do like 2 more minutes and then we should stop for questions and then move to the second talk.
Then I'm going to skip this case and go to another case. So here's a 75-year-old woman, mitral repair in 2006, AFib, low ejection fraction, AICD heart failure. As a TAVR in 2017, presents 4 months later with shortness of breath, transferred to Cedars for a type A dissection. And here you see the aorta. Is there a type A dissection? It's very weird looking. Doesn't, because the flow's not going in a kind of eccentric way. And when you look at the short axis, very peculiar. And then here's a sort of different angle. And now we see this, what the hell is this? We got slow flow here and something going here. And then, so what's it? Is it a section? Is it a rupture? It's a pseudoaneurysm. And so it's not that obvious. But and then here, this you can close it as we did here with an Amplatzer device. And here you see they just wired it and put the Amplatzer, and that closed their pseudoaneurysm. This is just examining, showing how they did it. So pseudoaneurysms are very problematic. They're usually related to prior aortic valve surgery, from the cardiac surgery aortic cannulation. They can also be related to trauma, inflammation, or be idiopathic. Most of them are repaired surgically, but in high-risk patients, we use endovascular repair with coils, thrombin, or occluder devices. There have been more than 40 cases of Amplatzer septal occluders showing good results in those patients. Our patient was alive at 3 years. So the timing of aortic surgery, life is short, the art is long, opportunity fleeting, experience fallacious, judgment difficult. That's what Hippocrates said. Just remember, bigger is not always better. Thank you.
That was fantastic. Thank you so much, Dr. Siegel.
Thank
Does
you.
anyone have any? No, this is amazing. And thank you to Paul for connecting us with Dr. Siegel. Does anyone have any questions?
Hey, Paul.
Hi.
Hi,
Thanks for a great talk.
it's good to
I wanted to ask you, I feel like it's good to see you too. Not every echo lab always reports index to height or body surface area. Do you, I know for Turner's patients especially who have short stature, I feel like I'm used to seeing that. Do you look at that for all of your patients, even non-syndromic patients with aortic aneurysms? You use the index values to track them?
Okay, so I only use the index value when I'm seeing them in consult. So that's not really, but if I have a patient, I mean, if they're short and you see that on the echo form, we have the height, then hopefully that catches your attention. But if the aorta is over 4 centimeters, I tend to look at that. But otherwise not. I think we would certainly be better off doing exactly what you recommend.
Great, thank you.
No, thank you.
Regarding the push towards, increasing the diameter threshold before intervening,
No,
is that
we're pushing for decreasing diameter threshold. That's what we're
decreasing? Is that because previously we weren't controlling hypertension as aggressively? Or is there something else we're doing in the management that's changing the thresholds, or we're just seeing that the natural history is more severe than we thought?
No, I think that what's changed is the surgery's gotten better. So before aortic surgery, the mortality was not insignificant and the morbidity was fairly substantial. Now, a lot of the surgery can be done, 3-day hospitalization. And so I think that's the key is the morbidity of the surgery. And one day we'll get the stent grafting at the ascending aorta, I hope, but we're not there yet. But so the descending we take care of now with a lot of stent grafting. And the ascending, we've got surgeons that are focused aortic surgeons. Before, 20 years ago, there were like 5 aortic surgeons in the world or the country. Now there's probably 50 in the US. So we've got 7 aortic surgeons at Cedars. 7. It's confusing, but they're good.
One more question. If there's discrepancy between different imaging modalities, how do you reconcile that? And do you prefer to just use one imaging modality to track over time? What's your preference?
So I think, though I'm the director of the echo lab, I hate to say it, angle can really be screwed up, especially if you have someone with connective tissue disorder where they've got a pectus, excavatum, or carinatum. Then that image, you may not get a good parallax. So I think 15 years ago, I would have said MRI. But now the CT dosing, the radiation's gotten less. And so I'm using more CTs than I was 10 years ago. But you have to know your lab. So CT or MR, I think, if you have somebody with an aorta of 45 millimeters or more, and you're kind of watching them, I get a CT or MRI to kind of validate what I've really got.
Awesome. Thank you so much, Dr.
Thank
Siegel.
you.
That was incredible.
It's been a privilege. Thank you so much. All right, bye-bye now. Bye.
Thank you.
Thank
So
you.
our next speaker is going to be Dr. Hamid, and I see she's logged on. So I'll go ahead and introduce Dr. Hamid, and then you can go ahead and share your slides. So Dr. Hamid is a maternal fetal medicine specialist and a cardiologist at the University of California, Irvine. She's board certified in internal medicine, cardiology, OB/GYN, and maternal fetal medicine. She is committed to cardiac disease and pregnancy ever since her cardiology fellowship years, and has more recently been actively engaged at the national level to improve maternal morbidity and mortality, particularly due to cardiovascular diseases. Dr. Hamid has served on the California Maternal Quality Care Collaborative Pregnancy Mortality Surveillance System since 2006. She's co-chaired Cardiovascular Disease and Pregnancy and Venous Thromboembolism Toolkit, which is published by CMQCC and AIM. She has also served on the ACOG Presidential Task Force to develop practice bulletins on heart disease and pregnancy, and she's engaged in cross-training of MFM and cardiology fellows through educational activities in the evolving field of cardioobstetrics. Dr. Hamid has funding from NIH and Betty and Moore Foundation to advance cardiovascular disease risk assessment in pregnancy and the postpartum period. And most importantly, she's a proud mother of triplet daughters. Thank you so much, Dr. Hamid, for being here today.
Thank you, Natalie, for the kind introduction. It's wonderful to be here and be connected to the fellows. That's wonderful. So let me share my screen. Can you see it? All right.
Yep.
So in the next 20 minutes, I'm going to update you as to what's going on in cardio-obstetrics and what does this mean? What is the anatomy and physiology of the team building when it comes to a cardio-OB patient? I will touch upon 4 areas. 1, the field of cardio-OB and the team. I'll present a patient and just walk you through as to how we managed her through our team effort. And then lastly, but very important, is the research and education piece that goes into the cardio-OB training. Whenever we talk about cardio-OB, is there a need? Is there interest? And everything is driven by interest and passion. As you know, the fellows who are more interested and who are putting in more effort, they end up publishing more and they are more engaged. So I think that's really important. And of course, they need to be supported. You need to have the support and resources to accomplish what you want to do. We all know, you may have seen this slide, which is the US maternal mortality rate. These are mothers who die of pregnancy-related causes within a year after delivery. As you can see in this graph, from 2018 to 2021, we have gone up from 17 to 32. We almost doubled in maternal mortality. You would have thought otherwise, right? We have so many more resources. We are working harder. We are taking good care of patients. Why is this happening? And I can tell you that amongst the maternal deaths, cardiovascular disease is the #1 cause. And that gives me a pause. When I reviewed, we still are reviewing maternal mortality cases, every single mother who dies in the state of California through CMQCC. And you go through their records and you find out that this more than half of the patients who died of cardiovascular disease actually died without a diagnosis of cardiovascular, attributed to something else or to nothing. And they were diagnosed in autopsy. Their hearts were really big, They clearly had cardiomyopathy that went undiagnosed. So really, that is the impetus of cardio-obstetrics, because there's a lot of overlap between the sign and symptom of pregnancy, cardiology, not right now, but in general, there's a limited experience of the cardiology fellows and the obstetricians, vice versa. And I put up this slide, and it's really interesting because this is from about 20 years ago when I was a fellow, and this was the reality. At the obstetrician's office, they did not want any cardiac patients if it went their way, and if you went to the cardiologist office, they don't want any pregnant patient. So again, there has been, and still there's a big gap that we need to fill, and that's where we are. And I'm so glad that you brought it up, because I really think you guys, you are the future. You are starting out your careers. Please look into cardio OB, make sure you know about pregnancy, because you're going to see more and more of them as you go along your career. And I'm so pleased to announce that you may know that ACC has a new section, which is cardio obstetrics, for the first time this year, which again is an effort by a lot of cardiologists that are in the background working on improving maternal outcomes. So when we talk about a cardiac patient, we know that an obstetrician is really good at doing what they do, and cardiologists likewise. But here we need the team. And it's kind of pieces of a puzzle. You have to really use the expertise of every member in your team to make a plan that would help your patient get through pregnancy safely, patient and the baby. And literally, a lot of these cases that are high risk end up somehow related, being in the cath lab and then being in the OR, getting the baby delivered, sometimes procedures in succession, sometimes procedures in the same setting, the same day. And anesthesia is really important because, of course, they're going to take care of the OB side of things, and they're going to take care of the cardiology side of things in a pregnant patient. There have been a lot of publications. So if you just put hashtag cardio-obstetrics, or you look up, just Google cardio-obstetrics, this area has exploded. A lot of great publications that was long overdue. And this is from Dr. Davis. And again, this is a central illustration published in JACC, where it outlines the cardio-obstetrics team and patients. And as you can see, for each patient, there's a bunch of different specialties that have to come together. Not only sometimes cardiothoracic surgery, sometimes we need to have social work and primary care, anesthesia, depending on the setting. So we need a team. And at every setting where there's a higher level of care, where you have cardiology services and where you have obstetric services, there is a great need of creating a team, identifying people who are interested from each of those specialties, who would be the point people if you come across a cardiac patient. And typically when it happens, when we have a patient, a cardiac patient, and we are coming together, not so much in the last 2 years with COVID, but we used to have in-person meetings, and now we are going back to it, where everybody really comes down to one place, and we present a case. We make a plan as to how are we going to take care of this patient. And then, this model for shared decision making not only applies to pregnancy and contraception, but everywhere, even in cardio, everywhere, whichever specialty you are in, you have to put into account when you're counseling patients, what are their values, what are their expectations, their preferences. You provide them information, recommendations, and then you make a plan. And that's where we are really for every pregnant patient, pregnant cardiac patient, should have a plan of care, particularly, frequency of follow-ups, when to deliver, where to deliver. So we're going to go through that in a case format a little bit later. So this brings me to a patient, and this is a patient from a few weeks ago, 19-year-old Gravida 1, who basically is a new patient for me in my OB office, maternal fetal medicine. She's 37 and 27 weeks. So I start talking to her, and I find out that she has a family history of sudden death, both in her father and her sister. Her father actually was in a car accident and was brought to the UCI Medical Center as because it's the closest trauma center, and he had passed out. That's how he got into this near fatal accident. It was found out that he actually has a Brugada syndrome. And then her sister, her younger sister, died in sleep. The patient was diagnosed with Brugada syndrome. She was offered ICD, but she was last year, about 18 months ago, but she was too young and too scared, and she did not want to have any intervention at all. So she was fortunate to be alive and healthy and pregnant and close to delivery. And one of the points that I wanted to bring up is out there in the community, you're going to see sometimes it's not recognized that this patient is a very high-risk patient. She needs to be at a center where she can get the care she needs much sooner than the 37-week mark where it's nearing delivery time. So I sent her to labor and delivery because I knew I don't have time. I can't arrange many people getting together. So I sent her to labor and delivery, and we had a multidisciplinary meeting there with the OB, MFM, cardiology, anesthesia, and nursing. This is one of the our labor and delivery rooms. The patient actually went to the room, got all of her testing done. And I'm going to share some of the things we know that with Brugada, there's an increased risk of ventricular tachycardias and sudden death in a structurally normal heart. And this is what this patient has. The diagnosis is generally made with a family history. It may be clinically silent. It may be an EKG that gives you a diagnosis. It's an autosomal dominant, and there are mutations that can be picked up, and that's how this family was diagnosed. When the father had sudden death and a car accident, that's how this patient gets diagnosed. And so we now knew this is what the risks are, and this is what the patient wants. And the right side EKG, this is an EKG, and I just wanted to put it up there. This is depictive of type 1 Brugada, where this V1 to V, as you can see, V1 and V2, you see this characteristic pattern, the coved ST segments that are greater than 2 millimeter. So this is her EKG. The discussion points really were, how do we deliver her, induction versus C-section? What are the medications we are going to use for anesthesia, pain control, and such? What type of anesthesia, what drugs to avoid, and what if she starts bleeding? How do we manage her postpartum hemorrhage? The three things you don't want to happen in a Brugada patient is exposure to sodium channel blockers, temperature, fever, which is quite often after a patient gets an epidural on labor and delivery, or sometimes with chorioamnionitis or infection in the uterus, or if there's an increased vagal tone. And remember that when the patient is ready to deliver and the patient is pushing, she's doing Valsalva at the delivery time. So all of these things we want to avoid. We also recognize that in anesthetics, these are the medications that we do not want to use, which is bupivacaine, usually used in epidural, ketamine propofol for intraoperative anesthesia, uterotonics, the methogen is contraindicated. Oxytocin also has theoretical risks on sodium concentration, and then anti-nausea medication. So we made a list of these medications. We made a plan to avoid each one of the things that we talked about, and the patient opted for induction of labor over primary C-section. It was offered to her. So then we decided this patient comes in and we start her induction and augmentation of labor. She's on continuous telemetry. She has defibrillator pads placed on the patient. There's isoproterenol at the bedside. We also are prepared if you need a perimortem cesarean section in an immediate setting. We have the C-section tray. She gets the Foley bulb with misoprostol for induction of labor. And our plan was to delay the start of Pitocin, like I said, because it does affect sodium channels, and there are some case reports not to use it. So patient progressed through the first stage of labor without complications. We didn't use any higher dose of Pitocin than 6 milliunits per minute. We also delayed neuroaxial anesthesia to minimize the exposure to local anesthetic. And we also knew that we would recommend a combined spinal epidural if she goes for a C-section. She received IV and IM morphine for pain control, latent phase of labor, and then CSE was placed active stage, and she actually went along to the active stage of labor. She was 8 centimeter dilated. So far, so good. Everything was going well. Now, in the first portion that I'm putting up there in black is the plan. The second stage of labor, we anticipated SVD. We wanted to minimize Valsalva, labor her down, consider operative vaginal delivery to minimize, again, Valsalva. Patient labored down for 2 hours, and she pushed to a certain station, but then she could not do any more. And we felt that the baby is not coming down. We tried vacuum-assisted delivery, but then baby could not be delivered. So then the decision was to go for primary cesarean delivery. So she had a cesarean section, and then she had a postpartum hemorrhage. So we gave her medications and avoided methogen. She got tranexamic acid. She got a hemabate. And overall, there was quite a bit of blood loss, well controlled. Things went well. We put her back to ICU, and then was discharged post-op day 2 in stable condition with the mother, with the baby and the mother. And then the outpatient, the plan was to get an ICD, and then her baby was also to be tested for Brugada syndrome. So that is an overview. And I bring this case up because a lot of times, ideally patients should get preconception counseling. They should, even before getting pregnant, if you know of cardiovascular disease, you optimize. If you get pregnant earlier on in pregnancy, you'd make the plan much earlier. But there are situations where it's very close to the delivery time. The only time is to get them in and get all the specialties together. So the last portion of my talk is about research and education. And I'd like to bring up, I know that there's cardio-obstetrics work group, and there's a subsection in ACC, and there are cardio-obstetrics journal club and case discussions that carry on. But we had started this fellow in training cases discussions a couple of years ago. And this was again to connect MFM and cardiology fellows. And we hold it 4 times a year on Wednesdays. So if anybody is interested, you let me know. We started actually 2 years ago, and we have people signed up until beginning of 2024. These are interesting cases, and we get experts from all over in cardio-obstetrics, whether this is a congenital or any case, cardiomyopathy. We have a good discussion, and both MFM and cardiology fellows learn. So if you're interested, any one of you, just send me an email, ame@hsuci.edu. And I'm just going to walk you through a couple of publications and the work we are doing. This is the Alliance in Maternal Health. This is ACOG, American College of OBGYN initiative, where we put together a bundle for cardiac conditions in obstetrical care, again, to improve awareness, education, and to inform institutions that are performing maternity services to have it in mind. And this bundle, you can go to Safe Healthcare for Every Woman.org, and you can download, read through what are the components of the bundle. So that was, and it was published early this year in the form of a consensus bundle in the Green Journal. And it's really helpful, especially if any one of you is interested in cardio-obstetrics or plans to be a point person. for a pregnant patient, I think it has a lot of information and tools that you can use. In addition, I would just like to introduce you to the CMQCC Cardiovascular Toolkit that I chaired. It was published a few years ago, and that basically brings together the experience for maternal mortality and creation of an algorithm to risk assess pregnant patients with cardiovascular disease. And this algorithm was validated in 64 cardiovascular deaths, and 93% of these patients would have been detected as high risk, requiring further workup. As I mentioned earlier, a lot of these patients, vast majority, actually were not diagnosed. And they had presented many, many times to the ED or to the primary care, complaining of shortness of breath, but nobody really paid attention because of the lack of awareness and education. So this is what we found in the maternal cardiovascular deaths, but then we took it forward, and we have a couple of grants that we are using the risk assessment prospectively in all pregnant patients. And there is more work that is being done at UPenn. You're probably going to hear about it, where they're going to implement the same toolkit in the emergency department setting. So as cardiologists, it'll be good. It's good for you to know that there is a resource that you can use, and you can determine if this patient falls into a higher risk category. So our goal really is to make it into, to develop it as a measure for Medicare and Medicaid. So it's a standard of care all throughout the country. And we have been working on the two risk or the two measures. One, all pregnant patients who come to an institution, they should be screened for cardiovascular disease. And then the second measure is the ones who screen positive should have a follow-up testing. And we implemented that into our EMR, which is EPIC at UCI, and a lot of other centers that we collaborate with. It takes about 60 seconds to get the score. And if they're positive, then it's automated next tests, which is EKG, echocardiogram, or BNP, TSH, depending on what the symptoms are. So I'm not going to go through this risk assessment. I had some screenshots. I think we are short in time, but I just wanted to reiterate that it takes a village. It really is not a one-person job when it comes to pregnancy and heart disease. You have to identify people who are passionate around you at your institution, from anesthesia, from cardiology, from OB, nursing, so that you have a team when this patient comes in, and you actually create templates for the dot phrases in your EMR, and you have a standardized way. Because I still get questions about, I just had a question from someone had called me and said, this is a patient, 26-year-old or 26 weeks pregnant, who had presented to ED. They called cardiology. The patient came in with chest pain. Her blood pressure was really high, and she also had troponins that were high. And the patient actually, they said, oh, this is because of preeclampsia. But that's not enough, as you know. If somebody in a pregnant patient who comes in with chest pain, who has troponins, those are the two criteria like you would use otherwise, right? This is a and STEMI, and there's always this risk of a SCAD. So always keep in mind, anytime you have a pregnant patient with chest pain and with troponins, that is in your differential. So I'd like to stop there. I know we are at the mark 6:30. I know that Natalie wanted to finish at 6:30 p.m. So I don't know if there are any questions that I can take. Thank you so much.
That was fantastic. Thank you so much, Dr. Hamid. Do any of the fellows have any questions right off the bat? Okay, I have a question for you. In terms of doing, advanced imaging or procedures that require radiation, how do you approach that with your pregnant patients, and how do you specifically counsel them about, getting a CT scan if necessary, or going to the cath lab if necessary?
Absolutely. That is a very good question. as a cardiology fellow and as a cardiology faculty, wherever you go, if you get a consult from pregnant patient for a pregnant patient, make sure that you have the same treatment plan as you would otherwise. I think that's one big advice that I give you. There are only a few things that you should be cautious. Of course, you don't want to just do a CTA for nothing, but this is, if say this is a patient with chest pain and troponins and EKG is normal and you're not sure which way to go, we actually do that routinely. We had a patient we actually diagnosed with SCAD who came in with chest pain, same exact scenario. Do the tests that you want, that you need, that you feel are appropriate for the patient. We also actually have done cardiac cath in a pregnant patient, and you counsel them because for the baby to be healthy, mother has to be healthy. So whenever there comes a point where you may have a catastrophic diagnosis, a life-threatening diagnosis, your goal is to keep the mother and make the diagnosis and keep the mother safe. So any of the testing, the only thing that I would say, which hardly ever applies here, is gadolinium. You don't want to use gadolinium during pregnancy, but you can use non-contrast CT at any time. You could shield the belly. You could do a radial cardiac. Cardiac cath is not necessarily recommended, of course, because of the vascular fragility during pregnancy and the risk of iatrogenic dissections and things like that. But still, there are techniques that you can use, and there is a place for coronary angiogram, the conventional coronary angiogram as well. So long answer, sorry about that. But the short answer is that pretty much every test can be done. I just had a patient who herself is a nurse who had a similar situation, chest pain, troponins, and she was 18 weeks, and I put her on the treadmill to see how is she somebody who should continue with the pregnancy, or how can I prognosticate her? So literally, you can do any of the tests that you do otherwise.
Interesting. That's good to know. Thank you. That's a great approach. Think of them as regular patients and manage their medical conditions first.
Absolutely. And same goes for medications. Like if you think, make a list, yes, you're going to, take off the ACE inhibitors and ARBs and stuff, but most of the medications, they actually are safe. The aspirin, the Plavix, the beta blockers, heparin, all of that.
One more question for you. I know it's probably hard to sort of rank the severity of cardiovascular diseases in pregnancy, but is it a general rule of thumb that you won't let any woman go into spontaneous labor, that you'll try to plan for an induction of labor or a planned C-section?
Not at all. Actually, ideally, you want a patient to go into spontaneous labor because that would be most physiologic, with least complications, with the shortest time in the hospital, and the lowest risk for a C-section. So ideally, however, there are situations where you want the patient to be in the hospital. Sometimes we do admit patients who are very high risk, in particular patients who are on therapeutic anticoagulation. We admit them to the hospital at 36, 37 weeks and switch them over to unfractionated and then deliver them. So timing of delivery is very important. Likewise, if you have a cardiac patient who has a prior history of preterm delivery, I'd be very cautious, keeping her pregnant very long. And what I try to do in my patients is at 37 weeks onward, I keep close tabs on how their cervix is, if they're dilated, if they are at risk for preterm labor and such. Ideally, you do not want a C-section in any cardiac patient except for aortopathies that Dr. Spiegel talked to us about. So aortopathies is one, Marfan's or decompensated heart failure. Those may be some conditions, but for the most part, all patients are better off attempting a vaginal delivery and not necessarily induction. Induction is more for timing and to have the whole team there.
Fantastic. Very useful information. Any questions from the crowd? Okay, looks like you've made everyone speechless.
Well,
Thank you so much.
or yeah, either got everything or did not get anything. That's how I feel. But thank you so much. No, I that was just a joke. Thank you so much. Thank you for having me, and it was a pleasure. And anytime, anyone, if you have any question about a pregnant patient, feel free to reach out. I'll be able to, if I'm able to help you in any way, I'd love to do that. Thank you.
That's fantastic. Thank you so much for that resource, Dr. Hamid. So we'll end the session tonight. And for everyone here, the session's recording will be placed on the California ACC FIT website. So thank you again, everyone that joined.
Thank you.